Okay, welcome to our presentation. We'll be discussing case study 1 by analyzing Mr. Shani's high priority clinical manifestation and the pathophysiological link to the diagnosis of anaphylactic shock and multi-organ dysfunction, MODS, while analyzing the diagnostic results and the appropriate pharmacological interventions to ensuring the use of holistic person-centered approach. Aradhana will be discussing criteria 1. Raja will be discussing criteria 2, which is me, and along with Shanae, sorry. Lauren will be discussing criteria 3 and Wissal will be discussing criteria 4.
Hi, Adrian Airway was assessed to be patent at the time of arrival, but he exhibited significant swelling on the right side of his face and mild swelling of the tongue, which raised concern for the signs of angioedema. Even though he could still speak, he was doing so in short sentences, which indicated early compromise of airway patency and justifies urgent intervention to prevent a complete collapse. His breathing was severely compromised with a respiratory rate of 30 breaths per minute and an oxygen saturation of just 86% on room air. He required high flow oxygen via non-rebreather masks to improve his saturation to 96%. On escalation, he had diffused crackles, wheezing, and stridor consistent with bronchospasm and possible early acute respiratory distress syndrome, which are serious respiratory manifestation of anaphylaxis. The circulatory assessment showed signs of hemodynamic instability. Adrian was hypotensive with a blood pressure of 87 by 48 mm on Hg, tachycardic at 132 beats per minute, and prolonged capillary refill time of 4 seconds. He was cool and clammy to touch, and peripheral pulses were weak, all pointing to anaphylactic shock. Neurologically, Adrian was drowsy with a Glasgow Coma Scale score of 14 and was not oriented to time, place, or person. Although his pupils were equal and reacted to light, the changes in his mental status are early indicators of central system involvement and multi-organ dysfunction. Upon exposure, he was found to be mildly hypothermic with a temperature of 35.7 degrees Celsius. He also had multiple sting sites on his limbs and face, with a foreign body noted in one of the sting sites. He also had widespread urticaria, pruritus, and angioedema, which are all classical signs of a severe allergic reaction. In terms of fluid assessment, Adrian was oliguric with limited urine output despite having intravenous fluid running at a rate of 80 ml per hour. His poor oral intake and the findings of highly concentrated urine with positive results for glucose, protein, and blood suggest early acute kidney injury. This indicates a progression towards multi-organ dysfunction syndrome. Finally, his glucose level was significantly elevated at 19 millimole per liter. This hyperglycemia may be related to his pre-existing type 2 diabetes mellitus, but also could be a stress response triggered by acute illness and systemic inflammation. This needs monitoring, as uncontrolled hyperglycemia can further complicate his recovery and increase infection risks. Thank you.
Thank you. So Mr. Adrian Shani represents with hypoxia with oxygen saturations of 86%. This can be linked back to his diagnosis of anaphylactic shock and his progression to MODS, which share similar pathophysiological mechanisms, often triggered by bee stings. Hypoxia occurs when biochemical mediators such as histamines, tryptase, chymase, and heparin have been released by immune cells called mast cells and basophils. These immune cells have been activated by binding to immunoglobulin E antibodies through bounding to high affinity AGE receptor. Um, so on mast cell membranes, during anaphylaxis, the myomedical mediators impact the lower airway, causing muscular edema, bronchospasm, and excess mucus production. These leads to extreme difficulty for Mr. Chenet to breathe, resulting in ventilation, perfusion mismatch, and poor gas exchange, potentially causing the low oxygen saturations. According to studies conducted by Massaro 2022, shock is a clinical manifestation of inadequate oxygen demand, progressing untreated anaphylaxis into anaphylactic shock. The biomedical mediator affecting the endothelial cells that are lined on the blood vessels, causing an increase of capillary permeability, ultimately affecting the upper airway, resulting in clinical manifestations such as angioedema and stridor. Once there is an inadequate supply of oxygen to the tissues, also referred to as tissue hyperperfusion, the tissue cells no longer use aerobic metabolism to generate andesine triphosphate (ATP), and cells are forced to switch to anaerobic metabolism, in which pyruvate no longer produces ATP but lactate, resulting in a buildup of lactic acidosis, leading to metabolic acidosis. So Massera and others 2022 agreed that the buildup of carbon dioxide in the lungs and blood leads to blood becoming acidic, stimulating the chemoreceptors in the medulla oblongata to trigger receptors in the lungs to breathe faster to balance the carbon dioxide levels. According to studies conducted by Badam and others, 2025, tachypnea is also a clinical manifestation of lactic acidosis. This explaining Mr. Shani, sorry, is experiencing a respiratory rate of 30 beats per minute. In addition to capillary permeability, smooth muscle relaxation causes vasodilation, where there is reduction in preload and the heart chambers are unable to fill. A decrease in stroke volume happens, leading to a reduced cardiac output, stimultaneously, sorry. Systemic vascular resistance, disease is due to vasodilation, which all contribute to the clinical manifestation of hypertension, evident in Mr. Shani's case with blood pressure readings of 87 out of 48. Thank you.
Anaphylaxis is a severe systemic allergic reaction and in some cases can lead to oliguria and acute kidney injury. As mentioned earlier, the release of the mast cells, basophils, and histamines in the blood leads to increased vascular permeability, capillary leakage, and hypertension. This results in renal tissues unable to receive adequate oxygen supply and blood flow. The inflammatory mediators such as tumor necrosis factor alpha, TNFA, and interleukins further damage the tubular epithelium and impair glomerular filtration. This causes retention of the endogenous and exogenous metabolites such as urea, potassium, phosphate, sulfate, and creatine, which the kidneys typically filter. This results in inadequate urine production and output. And this means that the body will attempt to remove these wastes through osmotic diuresis, which can lead to dehydration, nausea, and vomiting. Due to the decreased perfusion to the kidneys, the body activates the sympathetic nervous system, SNS, and the renin-angiotensin system, RAS. The stimulation of the RAS results in systemic vasoconstriction from the production of the angiotensin 2. This will stimulate adrenaline to be released from the adrenal glands, causing an increase in the patient's heart rate, as seen in this case study. The adrenal glands then release aldosterone and antidiuretic hormone, which stimulates water and sodium reabsorption into the kidneys. Through the activation of the RAS, the anterior pituitary gland secretes adrenocorticotropic hormone, ACTH. The ACTH elevates the production of glucocorticoids from adrenal cortex, leading to clinical symptoms of hypoglycemia. Referring to the case study, the patient has a past medical history of type 2 diabetes, and from this, there is also a greater risk of developing higher blood pressure. As the anaphylaxis response progresses in the body, the reduction in the circulating blood volume and impaired oxygen delivery can have detrimental neurological complications. The neurons in the brain are deprived of oxygen and glucose, which are critical for function, leading to manifestations of confusion and drowsiness in the patient. Thank you.
So multiple tests were taken to investigate Mr. Shani's case, including an arterial blood gas analysis, urinalysis, and bloods. Mr. Shani's ABG results on room air. They're visible on the screen with the normal ranges beside. His acidotic pH of 7.5 and his low partial pressure of carbon dioxide both indicate metabolic acidosis. He is severely hypoxic due to impaired gas exchange caused by airway edema, explaining why he's short of breath and confused. Despite respiratory compensation, he's still not adequately removing enough carbon dioxide. His low partial pressure of oxygen additionally shows significant hypoxemia due to the airway obstruction from the anaphylaxis and systemic inflammation. The stings have likely triggered a delayed anaphylactic reaction, which has caused systemic vasodilation, leading to hypertension and hyperperfusion. Due to the hyperperfusion, he's entered a metabolic acidosis confirmed by his lactate and bicarbonate ion levels and base excess results. As a result of the lack of oxygen being received by his cells, the cells are forced into an anaerobic metabolism producing lactic acid, which causes an increase in hydrogen ions. These increased acid results in a decrease in bicarbonate ions used to buffer the acids. Mr. Shani's elevated lactate level reflects a more severe metabolic shift towards anaerobic metabolism during anaphylaxis, aligning with the Perales-Corda et al. Paper, who identified increased lactate as a marker of severity and hyperperfusion in systemic allergic reactions. Mr. Shani's urinalysis results tell us that he is in acute kidney injury as a result of hyperperfusion, toxin exposure, and systemic inflammation. As indicated by the reduced glomerular filtration rate and with elevated BUN and creatinine. The presence of protein, glucose, and blood in the urine also suggests further glomerular or renal tubular injury. Mr. Shani's acute injury likely results from rhabdomyolysis and renal ischemia caused by these bee stings, consistent with Jasmine et al., where they describe myoglobin-induced tubular injury and shock-related hyperperfusion as key mechanisms. These results from the two tests tell us together that this patient is in advanced anaphylactic shock, where the hypoxia and systemic inflammation both are leading to multi-organ failure. Thank you.
So adrenaline, also known as epinephrine, is a symptomatic drug used in emergencies, generally as a first-line pharmacological treatment for anaphylaxis by rapidly reversing the allergic reactions and improving the airway, breathing, and blood pressure. It was stated by Rajiv, ETAL 2024, that adrenaline acts in adrenergic receptors, stimulating both alpha receptor and beta receptors, a type of G protein coupled receptors which are found around the body. Alpha-1 receptors that support anaphylaxis side effects of vasodilation due to the biochemical mediators. For example, histamines, by increasing intracellular calcium, causing the smooth muscles contractions. Vasoconstrictions and pupil dilation. Furthermore, the beta-1 receptors improve myocardial contractility, increasing cardiac output by activating ATP and converting it to CAM, which stimulates protein kinase A. This leads to an increase of blood pressure by increasing SVR, venous return, heart rate, and renin release, potentially raising Mr. Chanai's hypertension and improving organ perfusion. It also reduces mucosal edema in the airway through the stimulation of beta-2 receptors, causing bronchodilation, improving the wheezing, chest tightness, and shortness of breath. It also helps by inhibiting mast cells and basophils from releasing more inflammatory chemicals. Adrenaline is given through IM, which is the preferred route in anaphylaxis, while IV adrenaline infusion may be required if there is a cardiovascular collapse or no improvement. Hydrocortisone, also known as corticosteroids, it is an anti-inflammatory drug usually used as second-line medication, including antihistamine, but I will discuss corticosteroids as it helps reduce and prevent further swelling by blocking the production of pro-inflammatory cytokines, chemokines, cell adhesion molecules, and other enzymes. Reported by Alexander et al. 2023, this study also discusses the improvement of cardiovascular function and how it helps control ongoing allergic reactions. This is achieved by hydrocortisone having an immunosuppressive effect, which suppresses delayed phase hypersensitivity reaction therefore, it inhibits immune cell activation, especially B cells and T cells. Corticosteroids bind into an intracellular receptor called the glucocorticoid receptor, which undergoes change in cell nucleus, changing gene transcription, resulting in an increase of anti-inflammatory protein and suppressing their pro-inflammatory mediators. Alexander et al. 2023, when looking at Mr. Chani's case, although corticosteroids take several hours to activate, hydrocortisone helps prevent biphasic or prolonged anaphylaxis, the reduction of inflammation of the airway and capillary leakage help limit further progression of MODS by stabilizing the immune response.
Thank you.
Thank you.
So, as discussed, anaphylaxis is a potentially life-threatening condition that can quickly deteriorate. This case study explores the importance of effective recognition and management of a patient presenting with these signs and symptoms in an acute medical setting, as well as implementing a holistic person-centered approach, as discussed previously. To achieve optimal health outcomes for the patient's recovery, it is crucial to implement interventions such as prioritizing patients' airways, adequate oxygenation, and ensuring early administration of anti-inflammatory and vasopressor medical interventions. Thank you.
These are the references. Thank you for listening.